Hi, everybody. I'd like to continue with Chapter 3 in Abnormal Psychology on the topic of classification and assessment of abnormal behavior. Okay, so let me pull that up here. And here we go. Oops. Actually, let me start from the beginning. There we go. Alrighty, folks. Classification and assessment of abnormal behavior. So, our main topics will be the Diagnostic and Statistical Manual of Mental Disorders. We're in its fifth version, as well as the larger topic of psychological tests and measurements. Okay, how we assess human behavior. Alrighty. So, without further ado, alrighty. Now, the diagnostic manual for mental disorders is the DSM, the Diagnostic and Statistical Manual of Mental Disorders. It is currently in its well, it is called DSM-5, although it's really it's in its seventh edition. Yeah, I think I may have mentioned this before. We had the DSM-1, 2, 3. Then we had the DSM-3R revised. Then we did the DSM-4. Then the DSM-4TR, I think it was for transitional, um, temporary revision, transitional revision. And then we had the DSM-5. So it's kind of the seventh version. Alrighty. Um, so what this manual provides are several, about 17 or so categories of mental disorders. Okay. And within each category, we have specific diagnoses, right? Like major depression or bipolar disorder in the larger category of mood disorder. Alrighty. Now, diagnoses as a general matter are descriptive categories and descriptive um, uh, constructs. Yeah, so when you get a diagnosis, it's describing a phenomenon, the phenomenon of major depression. The diagnosis is not meant to be explanatory. Okay, it's not intended to tell you what causes it biologically, psychologically, culturally, and so on. Okay, by design, it's supposed to be atheoretical. Okay, although as we'll touch on a little later, the DSM is a manual that arises from the American Psychiatric Association, which is a branch of the American Medical Association. Okay, because of that, yeah, a lot of the diagnoses, the terms suggest a medical kind of framework in understanding it, and sometimes alludes to a biological component. Okay. Although technically it's the categories, not the large categories and the specific diagnoses are atheoretical in nature. Alrighty, but keep in mind that and you'll see it in the particular names for the diagnoses, and they imply a biological medical component. Alrighty. So the idea is that if you observe certain behavior, like decreased energy, decreased appetite, depressed mood, right? It goes to certain criteria, and which determines a specific diagnosis. Okay, and the individual needs to demonstrate certain minimum criteria to meet that diagnosis. If they don't meet the minimum criteria, they don't fit a specific diagnosis. They may fit another diagnosis or no diagnosis whatsoever. Okay, it's also possible to be suffering from more than one diagnosis. Okay? You may be suffering from major depression, anxiety disorder, and an eating disorder. Alrighty. Um, but as a general matter, most people will probably be diagnosed with one diagnosis, although it's very common to have a second, maybe even a third diagnosis. Okay, it's less common that you have five or seven or so. Some cases that may happen, but that tends to be the minority of cases. Okay, now the in order to be diagnosed, yeah, the nature of diagnoses are categorical. It's either yes or no. Okay, one, the behaviors are present or not, and then two, you meet the minimum criteria to be diagnosed, or you don't. Okay, but on top of either being in or out, Yeah, you either suffer from autism spectrum disorder or you don't. Yeah, it's also on a continuum in that you can be described as suffering from a mild depression to a severe one. Alrighty. Now, what's meant by no multi-axial framework? Okay. Previous um, iterations of the DSM had what was referred to as a multi-axial framework. Okay, so when diagnosing someone, you diagnose them along 5 parameters: axis 1, 2, 3, 4, and 5. Axis 1 involved all general diagnoses, psychiatric diagnoses. The axis 2 included personality disorders and developmental disorders. Axis 3, you would include physical disorders, medical conditions like, let's say, hypertension or heart disease. Fourth, axis 4, you would indicate a particular stressor, like, let's say, death of a spouse or divorce. And finally, fifth, you would it would provide a general assessment of functioning, a GAF, from a score of 0 to 100. Alrighty, 100 being fully functioning, 0 meaning, absolutely dysfunctional, right? Needing complete supervision and assistance. Right? But the DSM has thrown out the multi-axial system and has just relied on the a diagnosis or diagnoses. All right. Why is that the case? Well, to be quite frank, the makers of the DSM found, and I think they did some research on this, found that most people either weren't diagnosing along all 5 axes, or even when people did, a lot of the time people were not integrating the 5 axes into their treatment plans. Alrighty. I have to say, I think it's regrettable that the multi-axial system was tossed out, because I think when you looked at things along those 5 parameters, they did add some helpful information. Yeah. Or it was important to remind oneself that whatever psychological stuff is going on, there are medical things going on. Or it's important to kind of always keep in mind what are the stressors going on as well, such as, death in the family and so on. Yeah. And to always think in terms of general assessment of function, so that we're not just so focused on someone being diagnosed as suffering from anorexia, but really how are they functioning in other things, socially, work, and otherwise, which I think the GAF kind of made you conscious of, mindful of. Okay. Um, Other changes in the DSM, new orders were added, such as hoarding disorder, wasn't present before. Um, it was a tentative diagnosis, but it was not an official diagnosis until the DSM-5 came out a couple years ago. Okay. Other disorders were reclassified or consolidated together. There used to be a separate Asperger's disorder and a separate autistic disorder, but now they've been thrown together in this general category of autism spectrum disorder. Okay, but again, you could describe it as mild or mild autism versus severe autism. Yeah, mild being, where Asperger's would typically fall. Okay, and then severe autism, including those who have minimal communication abilities and have and require, constant supervision. Now, what are some points of controversy with the DSM? Okay. Well, one will argue that there are too many darn diagnoses. Yeah, I think the total list, if you count every single separate diagnosis, comes out to about a couple hundred. Yeah, so there seems to be a diagnosis for everything under the sun. So that's what's argued. Yeah, and it may be argued that some of those diagnoses are too liberal, or it's too easy to diagnose someone as suffering from something. Yeah, and that, maybe some of the motivations in increasing the number of diagnoses, making it so easy to diagnose someone, had to do with more financial incentives. Yeah, so that therapists and psychiatrists and psychologists could get reimbursed. So that's certainly a point of contention and controversy. Okay. Other disputes could concern, throwing in Asperger's with general autism disorder, and changes in some of the diagnostic criteria, which may not have been sufficiently validated by empirical research. Yeah, that may have been driven by more arbitrary subjective experience, or arbitrary clinical experience, and so on. Okay. The the process of coming up with the categories and the specific diagnoses and changing criteria or adding, modifying, or throwing them out involves a process, generally speaking, of a few to several years where there are committees formed by the APA, by the APA's DSM um, committee, larger committee, to make subcommittees for each of the categories. Subcommittees may be as small as several people and upwards of 15 to 20 people, usually psychologists, psychologists, social workers, and other experts in the field, okay, who meet for a period of time and determine whether changes are to be made as I just described. Some of the concerns with these committee meetings are their degree of secrecy. Yeah, many of these meetings were not open for the general public. Yeah, so some question how transparent the process was in determining revisions. Okay, for some diagnoses, there are some individuals who felt like they were excluded from the process, and whereas because of their expertise, they should have been included in particular committees. Alrighty, and again, the inadequate level of empirical bases for some of the revision changes. Alrighty. Another critique as an increased degree of medicalization that we can see strewn throughout the DSM with various diagnoses and particular terms or criteria that were added, which seemingly gave the DSM much more of a medical model kind of a approach, do I dare say, feel to it. Alrighty. For example, whereas a diagnostic criteria may have been simply described as repeated temper tantrums for conduct disorder or oppositional defiant disorder, they were changed to disruptive mood dysregulation disorder. Alrighty. So rather giving a more plain meaning or behavioral meaning of a temper tantrum, right? Now it seems to be a dysregulation disorder, which suggests more of internal biological kind of dysfunction. Okay, now what are some of the advantages and disadvantages of the DSM system? Okay, well, one, just plainly, it allows mental health practitioners and researchers in the science to communicate. Yeah, have some kind of universal agreement as to how we operationalize different categories. And to that extent, it served that purpose and served that purpose quite well. Okay, it certainly allows mental health practitioners across different disciplines to communicate things effectively and efficiently. Okay, now what are some disadvantages? Again, as kind of alluded to, perhaps now we have more of a perspective, a medical framework perspective on examining diagnoses. The DSM although used to identify problems, is less good at identifying or incorporating behavioral strengths, yeah, in terms of understanding phenomena, yeah, as well as behavioral weaknesses, yeah, looking more at the symptoms, but then what are other behavioral weaknesses and strengths that can help us understand the underlying pathology. Okay. Let's see. There's, as mentioned before, we have more of a categorical model as opposed to dimensional approach. Okay, although it does provide for both. And finally, as has always been the case with the DSM, yeah, there's always the concern about the stigmatizing effects of characterizing, a problem in eating as, say, anorexia nervosa or bulimia. Now, do those different category diagnoses and patterns exist? Sure, they do, and there's a lot of good epidemiological support for that. Okay. That said, once you label someone as suffering from anorexia nervosa, yeah, does that kind of stick with them? Yeah, is it on their permanent record you always hear about? Well, I'll leave that to maybe later discussions we'll have in terms of diagnoses and their meaning outside of the science, outside of clinical purposes. Okay, here's a criteria for major depressive episode, of a major depressive episode. We'll probably go into this a little later when we have when we meet face to face or via Zoom. Alrighty, let's talk about some methods of assessment. Alrighty, now there are two terms to be kind of familiar with: assessment and tests. Alrighty, and they are distinct, although related. There's some overlap. Assessment you can see as the larger umbrella, yeah, and it's any attempt to collect information so that we can come to some kind of determination or evaluation about someone's functioning. Okay, IQ, personality, and so on. Okay, that data might be from a test, or it may be from classroom, hospital observations, it may be from interviews, whatever, right? Biological lab tests. All these points of data go to assessment, fall under the larger umbrella of assessment. Whereas tests, you're talking about a specific instrument that quantifies, yeah, behavior, right? So think of this isn't a test, but it always helps me remember exactly what a test is as opposed to a clinical interview or going through medical records or legal records. Uh, think of a ruler, right? That's an instrument, right? Very simple one, which has inches or millimeters, centimeters, the metric system on it, and it quantifies, right, distance, right? So, and much like that, a psychological test is a specific instrument that quantifies, yeah, puts a number to behavior, whether it's personality, IQ, or whatever behavior measuring. All righty, well, let's look at the different methods of assessment. First is the clinical interview, right? Which may last anywhere between a few minutes if it's in an emergency psychiatric room and you're doing triage, trying to assess exactly what the person needs as they're being brought in by the ambulance or police or family members. Or it may last upwards of 50 minutes, 50 minutes, or maybe a couple hours, right? Couple different interviews, each lasting about an hour. All righty. Well, during a clinical interview, some of the things you would want to do is identify the presenting problem. Why is the person here today? Yeah. You'd want to collect psychosocial history as well as, which includes, social functioning, school performance, work performance. You'd want to collect history on medical problems, medications, treatments, surgeries, injuries, head injuries in particular. Um, and you'd also want to include legal history, yeah, if relevant, yeah, and also other general identifying data, yeah, in terms of family background, family history of some of these variables. Alrighty, so that you can come to some conclusion about what the presenting problems are, but even more specifically, what diagnosis are they suffering from, and then what mental disorder or disorders may they be suffering from, but also what is the right course of treatment. Let me stop here, pause for a moment. Okay, let's continue. Thank you. Just have to take a little breather there. And let me pull up the slide. There we go. So after a clinical interview, as part of a clinical interview, what's very commonplace to perform is what's referred to as a mental status exam. Okay, now a mental status exam includes a series, typically anywhere between 12 to 15 questions, which allows you in about 5 to 10 minutes to assess a lot of information very quickly. It's kind of a quick and dirty assessment so that you can determine, so that it can help you determine, and probably in broad strokes, what's going on with the individual. So part of a mental status exam, it's kind of a checklist. And what you do is you go through things such as, how does the person appear? Do they appear, in terms of level of consciousness? Do they seem to, personal hygiene? How are they clothed? And so on. Yeah, you would do some tests, like 2 or 3 uh, questions, which would allow you to assess their level of attention as well as concentration. Yeah, their ability to work, not just attend to sensations, but work with information. So a test of concentration would be to ask the client to spell the word world backwards. Okay. You would also find the orientation to time, place, in person by asking them a few questions about, such as time, what year is it, what season, what month, what day of the week, and what time it is, what hour of the day. Alrighty. Um, Now, the reason why you ask them about time, place, and person, okay, it's a good rough indicator of their level of functioning or or the severity of their functioning. Yeah, when someone is impaired, um, usually the first thing to go would be some sense of time. So there may be some disturbance with that. It could be as severe as thinking that it's 1998 when it's actually 2021. But often, someone will be off by just a couple years if that's impaired. Or if it's not that bad, it might be something subtle as thinking it's 2 in the afternoon when it just is midday. Okay, just a subtle impairment in time perception. um if you want to assess place, you might ask them things such as what country are we in, what state, um what city, what building is this, what department, and so on. Yeah. And then finally, you ask them, in terms of person, who are they, can they provide their first and last name. Yeah, but the idea that with more impairment from time to place to person. Yeah, the more you have impairment in that direction from time to person. Okay, well, within time, the severity of that, then place, and then person. Maybe may be a pretty good. It's probably a good indication of their level of functioning. Yeah. So if someone, the only thing that they're a little off with is that they think it's 2 in the afternoon when it's 12, might be coming from someone who's suffering from a major depression, yeah, which is moderate at this point. Whereas if someone thinks it's 1998, they think they're in San Francisco when it's actually Honolulu, and then when you ask them for their name, they say they're Steve Jobs. Yeah, that person is probably really severely impaired, probably in some kind of psychotic state. Alrighty, so orientation is the other. You'd want to assess for mood, if it's depressed, what degree of depression. As an aside, if anyone ever reports, as many people do, who come to outpatient clinics, private practices, or hospitals, if they report depression, you have to always ask and assess for suicide. Okay. In a later chapter, we'll talk about how you do that. Yeah. But if you don't do, if someone presents depression and you fail to assess for suicide, I mean, I think that's arguably negligence, professional negligence. I mean, the two go hand in hand, depression and suicide. Yeah. So even if they don't state it, ask it. It doesn't hurt to ask. Okay. You want to also, there are also several questions for perceptual and thinking processes. Yeah, that get to if they're sensing things, what kind of sensations they're having. Are they hearing things, seeing things? Yeah, or other kinds of sensory distortions. Yeah, tactile, olfactory, and so on. Gustatory, taste. Alrighty. And then you might want to ask a couple questions about just to assess their logical reasoning as well. Okay, and finally, you want to get a sense of their judgment. In particular, you want to see to what extent they can, to what extent impulsivity may affect their ability to make the best, choose the best consequences, choose the best options for their own well-being. Alrighty, so that's generally what a mental status does. You can do it in about 5 to 10 minutes, and you can get a lot of information, which can kind of help you steer the person in the right direction in terms of what they may be suffering from in terms of a diagnosis, but just as importantly, if not more so, um, helping them get the right treatment. Okay. Oh, we might look at this mental status exam, this example of one when we meet. Now, let's talk about psychological tests. Okay, so this is a big part of our discussion. Now, in terms of psychological tests, there's a whole course on this called Tests and Measurements. I'm just going to very quickly and briefly go over some of the major psychological tests which you will frequently encounter either in private practice and in outpatient counseling center, in a psychiatric hospital. Okay. And I'm just going to go over very quickly what each type of test or what kinds of information each test provides. First is our intelligence test, like the Wexler Adult Intelligence Scale, which is in its fourth version. We're going to be starting the fifth very soon. I say third edition, but it's fourth edition. Sorry, that's typo. And the Stanford Binet Intelligence Scale. Okay, the one that's used the most in the world is the WACE, but the Stanford Binet is a close second. Stanford Binet is probably more often used with children and adolescents because it has because of the way it's structured, it allows for a very finer distinctions in terms of cognitive functioning that may occur more with children and adolescents. And the age cutoffs for intellectual performance, cognitive performance along a bunch of parameters is more finely attuned for children and adolescents. Yeah. Um, but the Wexner adult, the WACE is the most commonly used. There's an adult version, there's a children's version, as well as an infant version as well. Now, intelligence is, first of all, the gross measure of intelligence is the IQ, and there's a full scale IQ. You can think of that. That's usually what's thought of as the IQ score. Alrighty, but there are actually four sub IQs: one for verbal reasoning, visual spatial reasoning, memory, which is really important, as well as processing speed. Yeah, the two latter IQs tending to be more neurological, neuropsychological in nature. Yeah. And the IQ here's are some examples. Some of the IQ test is composed of about 17-ish subtests, and here are a listing of some of the common subtests that are in the IQ. And they're broken into for um for our purposes here just into the two verbal and performance IQ into those two major categories. And you can see on the verbal, there's a test on general information like what day is Independence Day, how are two items similar, in other words, assessing a person's ability to think abstractly or categorize. There's some math reasoning, vocabulary, which is one of the best predictors of overall IQ. General knowledge, do people understand why someone would buy insurance, or why you know why people are taxed? What's the reasoning behind that? Whether you agree with it or not, what's the reasoning behind it? As well as a memory test, yeah, for attention and concentration digit span. Under the visual performance category, we have picture completion, in which you're supposed to look at a picture and figure what's missing. Picture arrangement, where you're given a number of pictures in a set sequence, and then you got to reorder the pictures so that they tell a story. Yeah, this test subtest is a good measure of logical reasoning and social reasoning. Okay. We also have block design for visual spatial reasoning, kind of a puzzle test, object assembly for similar visual spatial reasoning, and finally, digit symbol substitution. Alrighty, in which you're supposed to, as fast as you can, write the number for every symbol, right? Every symbol has a number, then you got to write the appropriate number, 1 here and 5 here, and you're timed on that. Okay, so it gets at visual spatial memory and processing. Okay, we'll kind of bypass this. So, and by the way, what's just as valuable, if not more valuable, than knowing an individual's IQ or the four sub IQs, yeah, um, is understanding how they perform along all these different types of subtests. Yeah, because by knowing individualized performance on each of the separate IQ subtests that we got listed here, we got about several of them here. It can really give you a very good idea of what the problem may be in terms of what's going on at work or school and so on. Yeah, and perhaps even with other issues regarding their psychological functioning beyond school and work. Although those are the two common areas in which IQ data is really helpful. Another type, category of tests are objective personality. Well, there are objective, and then we'll get to projective personality tests. Generally, personality tests are commonly um, administered to clients or patients when we want to get a better sense of their functioning. Very often knowing a diagnosis doesn't really tell you some of the underlying personality constructs that may be helping or not helping them to adapt. Yeah, at home, at school, at work, and what have you. But sometimes a personality test can help kind of shed light as to exactly what are the interpersonal behavioral dynamics that are affecting the individual's functioning. Alrighty. Now here are some common. Here are two of the common personality inventories. Okay. Now they're referred to as objective personality tests because of the structure of the test. Each of these tests tend to involve multiple items, like the Minnesota Multiphasic Personality Inventory has about 500-ish questions, true false items. Yeah, where individuals endorse true or false a number of behaviors, like have they ever had angry thoughts, or have they ever cried? Do they think owning a flower shop would be pleasant? Yeah. So two, like the two former examples I gave you, makes a lot of sense as to why they would be in there. But there are also some very unusual items, seemingly random items, that have also made it into the MMPI test, which seem to be effective in terms of um, elucidating someone's personality functioning. They statistically were correlated with different personality constructs. Okay, so the MMPI is structured as such, and because it's there are hundreds of these items that ask about a multitude of behaviors, and all you indicate is you're fixed in terms of how you can respond, right? So it's a fixed response, either true, false. Others might have might be on a Likert scale response, right? But because it's fixed, quantifiable response, yeah, you can objectively score them, right? So someone completes a MMPI questionnaire, right? True, false for about 500-ish items. Similarly with the Milan, I think the Milan is maybe a few hundred, but similar type of closed response, alrighty? They can be scored objectively, and then based on that data, right, a computer software program generates um, a profile of the person's clinical or personality functioning based on the data provided in this objective test. Alrighty. The most used globally in the world personality inventory is the Minnesota Multiphasic Personality Inventory. It's one of the earliest objective personality tests made. It's highly reliable, valid, has good validity data as well. And there are just thousands of studies supporting its use. Okay. Similarly, with the Milan Clinical Multi-Axial Inventory, the difference between the two is that the MMPI tends to be a personality measure that provides a clinical picture. Okay. The Milan does as well, but its picture actually kind of steers the clinician more so to a specific diagnosis, and which the MMPI does not do. All right. It might point to certain things, but the Milan is particularly well designed to fit or comport with the DSM. And we'll kind of bypass this for now. So this is an example MMPI profile. Yeah. Here we have uh, what we would have, just to kind of illustrate, would be several clinical scales. And then what's clinically relevant are those things that are those so you'd have like 10, there are some validity scales and 10 clinical scales, and wherever the person spikes above this blue line or below, you can barely see it, this black line here, those are clinically relevant. Yeah. So for here, I think this is about where depression would be, this is where psychopathic deviant would be, and this is where schizophrenia would be. Because they spike, it suggests that there are some features of depression, psychopathic deviant, and schizophrenia, which characterizes this person's functioning. Yeah. But I do want to make a note. The thing that's really a strength of the MMPI is that it's not a rule, it's not an immediate rule in or rule out. Okay. It depends. It depends on how high the spike is. We can see the person is mildly depressed, some psychopathic deviant, but it's not like up here, and some features of schizophrenia, but it's not like up here. Yeah. So it depends on how high the spike is or how high the dip is in this case. Alrighty. And it also, you have to interpret it in light of the relationship between these different scales. All right. So if this was here, but these two weren't spiked, that's going to lead to one interpretation. However, because you got this going on and here, this going on here, you get a finer picture, yeah, of some of the variables at play in this person's functioning. So that's one of the main reasons why the MMPI is really a popular measure among psychologists, besides its great empirical support. Okay, let me stop here for a moment. Okay, and again, thank you for your patience. Let's continue. So projective personality tests. Now, projective personality tests are different than objective personality tests, whereas the former is uh, that has a set series of numerous questions, hundreds of questions, with fixed responses, right? True, false, Likert scale, multiple choice in some circumstances, which leads to objective scoring, right? So whatever results you get isn't a function of some subjective judgment or clinical experience. It's just based on the answers you give, yeah, and then as it goes through the computer software, how your responses are statistically analyzed to produce a certain quantifiable profile. Okay. Projective tests are almost the opposite, not the opposite, but differ on almost each of those characteristics. Okay. First of all, there are only a certain number of stimuli, like pictures or a blank sheet of paper. The instructions are very simple. We're not talking about hundreds of questions. They're often just a handful of prompts where you're asked to draw something or complete a sentence. And then this is where projective tests are weak and usually more criticized. They're scored based on, in most cases, the clinician's judgment, their subjective personal experience or clinical experience, again, their personal experience, as opposed to a standardized, normative database. Alrighty. So why are we talking about, and projective tests are related to that, and maybe not so uncommonly related to that, to this, to these characteristics, regrettably don't have a lot of empirical support. And what empirical support they have is usually weak. Alrighty. Well, why are we talking about projective tests? Well, regrettably, they are still commonly used. Alrighty, for a variety of reasons, which maybe I'll hold off to. I'll leave the test and measurements class for us to have that discussion. Okay, but they are still with us. They're still given in many graduate. The training of administering projective tests are done in many clinical psychology graduate programs still. And so because you will probably encounter this kind of data, I think it's important to be familiar with it. Alrighty. The idea with the projective personality test is that, well, the theory arises from psychodynamic theory. The idea that we may repress certain unconscious motives and wishes, very typically sexual or aggressive in nature or unwanted, right? We repress these things because we don't want to think about them. That's the idea. And that if you provide some kind of ambiguous stimuli, like a blank sheet of paper, an ink blot, a picture, and asking someone to tell a story, that people, when they engage in these imaginative, creative kind of exercises, will invariably have some of their motives, unconscious material kind of leak out. Alrighty. So the clinician can pick up on, as opposed to just asking someone, hey, do you have violent thoughts about hurting, people, right? Do you have, odd sexual proclivities, which, most people might say, no. But the idea is that through these projective test, some of that stuff will kind of leak out. Hate to use the word leak, but will kind of sneak out, will show themselves because the person's not consciously thinking, right? When someone asks you, do you have violent thoughts against others, right? You can consciously process that and you know, oh, that's a bad thing. I'm not going to reveal a bad thing, right? Or I'll repress a bad thing. But if you get involved people in imagination or creativity onto kind of a ambiguous stimuli, like a blank sheet of paper, and asking them to draw a figure, that exercise will reveal some of the unconscious feelings, motives, and drives. Alrighty, that's the idea. Some of the major ones include the sentence completion task, the Rorschach, and the thematic apperception test. And figure drawings is another one. Okay, with incomplete sentences, we'll get to this maybe when we meet in person. Alrighty, kind of go through that. Let's touch on the Rorschach test. The Rorschach was created by physician Hermann Rorschach. I think he was Swedish, in his 30s. And Rorschach had created this test when he had when he was thinking about a grade school game. And what the game was involved maybe wasn't just in either Sweden or Switzerland. I apologize, not exactly knowing which of the two, but a Swiss or Swedish game where children would drop some ink on a piece of paper, fold it, and then they would ask themselves, oh, what do you see? What do you, it's an imagination game, like looking up at the clouds and do you see a horsey or whatever, right? Well, Rorschach wondered if these ambiguous stimuli, the ink blots on a sheet of paper, if children saw different things, would different psychiatric patients see different things? Like would depressed patients see certain things, patients suffering from schizophrenia see something else? Yeah, those suffering from violent ideation or actions, would they see other things? Well, Rorschach, taking this game into the psychiatric hospital he worked in, made the observation, came to the conclusion that different categories of diagnoses, people suffering from different categories of diagnoses, saw different things. Okay, so that's kind of the idea. So here's an example of an ink. We'll probably chat about some of these later. Okay, and the idea is that people, well, from Rorschach's original idea, decades later, I think it was somewhere in the 70s, yeah, Exner developed a comprehensive system of how to score these ink blots. Yeah, and the scoring system is based on the use of, the outline, the form, the color or shading, um, you know, whether the person saw things that were commonly seen or saw things that nobody else saw. And along all these indices, Exner collected normative data to find out what the average person would say or see, or how they would see it versus, how your specific examinee would see it. Alrighty. So Exner kind of molded this test into more of a sensation, perceptual, thinking, affect test. Where you can score along all these parameters based on how someone makes sense of these ink blots. Alrighty, how they look at it and process it, and so on. Alrighty. Now that said, even though Exner kind of modified the test so that it could be based on normative data. Yeah, you can come up with a specific score, like the use of the outline or the form, and then compare that score to a normative base. Yeah, making it a better test. Yeah, because it had norms. You could take someone's score and then a specific quantifiable score, and then compare it to the normative data, making it a better test. It's still subject to dispute as to the validity of some of the conclusions which Exner proposes that you can make after scoring someone's Rorschach ink blot responses. Okay. The other projective test is the thematic apperception test. Alrighty, it's a very simple test where you show a subject a picture and you ask them to make up a story. Alrighty, you ask them to say how the story begins, what's going on, and how it ends, and what the characters are thinking and feeling. The idea that what people say, they see, what the story they make up tells something about their ego functioning, their ability to, modulate impulses and, gratify themselves in a realistic, appropriate manner versus not being able to do that. Okay, so we'll look at some of these pictures and discuss them. And finally, we have the human figure drawings. And the administration of the human figure drawings is fairly straightforward. You give the examinee a piece of paper, 8.5 by 11 paper, you hold it up vertically. Well, don't hold it up, you put it on a table, and then you ask the person to draw a person. You ask the client to draw, the examinee to draw a person. And after they draw a person, you ask them to draw a person of the opposite gender. Okay, so you give them another sheet of paper, or sometimes you flip the same sheet of paper over. Other variations include drawing a family. The other one is a house tree person. And the idea is that whatever someone draws, yeah, it will be a projection of inner issues or conflicts. Yeah, the idea you can, speaking maybe generally about the process of projective test interpretation, is you can look at projective test interpretation kind of like art interpretation. Yeah, and that's what we do with fine art, right? You can see a painting and you get a sense of what's going on with the artist, right? Right. That's kind of the idea with figure drawings. Alrighty, but as mentioned before, like many other projective tests, empirical support for conclusions or interpretations based on people's drawing, whether they draw the head big or they draw a lot of hair or, a lot of teeth. And what does that mean about the person's psychological functioning is up for grabs. And not a lot of great empirical support. Okay. As an aside, figure drawings are commonly used in child therapy. Yeah, but typically not as a projective test, but as a way to engage the child in talking about things. Yeah, because it's something that's common for children to do, right? In grade school, to draw stuff, their family and things that happened. So that's the idea. Very commonly used in child therapy. All right, but not pursuant to the projective theory. Okay, so we'll probably look at some examples of figure drawings when we meet. And finally, the last group of psychological tests which we will probably encounter will be neuropsychological tests. And neuropsychological tests essentially are tests which measure a brain functioning. Yeah, so we're looking at brain functioning like attention, concentration, memory, organization, planning, and even things that get into the realm of personality like impulse control and so on. Alrighty. These tests are very typically given when people have problems at school and work. The most common referral question will be memory problems. Okay, and these tests are often very good in order to assess one's cognitive strengths and weaknesses. Yeah. Sometimes neuropsychological testing will also incorporate personality testing, typically objective personality testing, to see the possible interaction of personality with cognitive functioning. Yeah. So to maybe sort out if someone's referred for a neuropsychological test for memory deficits, under the assumption that it must be because it's an elderly, let's say it's an elderly patient who's being referred for this referral question, because the presumption may be, oh, maybe early signs of dementia. A neuropsychologist may want to do personality testing to see to what extent depression may be at play, and to maybe sort out whether the memory deficits one is observing is a function of depression and or a function of aging or dementia. Okay. And with that, I think that's all I have to say about neuropsych testing. I think I'll leave it at that. Yeah. Let's just bypass this. Oh, one other thing. Sorry. Let's get back away from psychological tests. And I'd like to talk a little bit about behavioral assessment. Okay, this is kind of information you will run into frequently. Okay. And probably the area you'll find it most frequent is with child adolescent work. Alrighty. So the idea with behavioral assessment, as the terms kind of suggest, is that you're getting information. Like this is apart from tests, right? But behavioral data. Yeah. So, for example, maybe it's a child with ADHD, and you're collecting data on how often they get up out of their chair, or how often they enter a class, or talk during class, or touch other kids during class. And sometimes if you just have a psychologist plant himself or herself in a classroom for just a couple hours, right, and you divide up the counting of behaviors into little 3-minute segments, and you can collect a ton of data about how a child may be functioning who's suspected of suffering from ADHD. Now, that's just an example. There are some general principles with behavioral assessment. Yeah. First of all, it includes collecting data on overt behaviors. Alrighty. So some of the examples I just mentioned with ADHD. Alrighty. When you're working more cognitive behaviorally, you may also include um, um, covert behaviors, thoughts, attitudes, beliefs, things the child is saying to himself. Yeah, so when they make a mistake, are they saying to themselves, "Oh, I'm dumb, I can't do it, I hate the teacher," stuff like that? Or are they telling themselves, "Oh, it's a mistake, I know if I try at it, if I persist, I work at it some more, I'll eventually get it." It's frustrating, and the latter former statements are certainly more concerning than the latter statements. Yeah, but that's also can be part of behavior assessment, covert behaviors. Alrighty. Also, part of behavioral assessment is collecting data on antecedents and consequences. Yeah. So, what precedes certain behavior that you're observing in an adult who's suffering from a major depression? Are there certain, before he or she gets into a crying fit, are there certain stimuli, antecedents that seem to bring on the crying? Is it time of day? Yeah. Is it certain people or certain stressors? Alrighty. And also, what are the consequences? Yeah, for certain behaviors. So, for the person who's suffering from a major depression, when they do try to act assertively to control their environment to be effective, do they get rewards? Are they punished, or are they punished by people? Yeah, are family members reinforcing them positively, supporting them when they try to act assertively, or do they punish them for acting assertively? It sounds counterintuitive that loved ones would do that or coworkers would do that, but it happens. Yeah, and that's important to understand the reality that what affects behavior are the consequences, reinforcements, positive, negative, as well as punishments, positive and negative. Okay. And what's really handy about behavioral assessment is that it's the data you collect is can be very tightly interwoven into your treatment plan. Yeah, it's also something, the kind of data that makes very clear sense to the client. Yeah, stuff that they want to change and being able to observe it and count it can allow the client to have a large degree of control over their behavior, which they might not have had before. Okay, and with that, that's all I have to say about diagnosis and psychological assessment related to abnormal behavior. Alrighty. With that, I look forward to us getting together and speaking about some of these issues. And with that, again, thank you for your attention, and I will see you in the next chapter, chapter 4. All right. You take care. Bye bye.